Hello, class. I'm back again. We're going to talk about, we were talking about how the Blue Cross plan came into being in the 1929, and then employee benefit plans became popular in the 1940s into 1950s. Then we had union workers. This represented a large group of workers that bargained for better benefit packages, including tax-free employment sponsored health insurance policies. You might want to look up unions prior to us getting together tomorrow. So during the 1950s and 1960s, the government programs began to cover medical expenses. So in 1965, the federal government enacted two programs for health care reimbursement. That is Medicare, which is designed for the elderly, and Medicare that's for the elderly, and Medicaid that is for lower income families. The HMO came into being in the 1970s. This allowed for more use of funds and policies to promote healthcare maintenance organizations. That's why it's called a HBO. They actually manage the patient's care. They tell the facility how much they can charge for a particular service. The managed care is intended to reduce the inefficiencies in Medicare and provide better care at a lower cost. So about 1989, as health insurance continued to evolve, we got the DRGs, which are known as the diagnosis related groups. This was implemented by Medicare to help with to control medical spending. So by 1990s, mid 90s, most Americans were enrolled in health insurance plans that were managed cares. But in 1995, individuals and companies paid half of that health care received in the United States, and the government paid the other half through Medicare and Medicaid and other programs. About 60% of the American population have health insurance through their employers sponsor programs, but it has been estimated, and it's still true, that there are roughly about 45 to 50 million Americans who do not have health insurance. So, what do you do with that, knowing that people do not have health insurance and they cannot afford to go to the doctor? How do you handle that ethically as yourself? How do you feel about that? So, in 2010, the Patient Protection and Affordable Care Act was passed by 2010. Congress passed the Patient Protection and Affordable Health Care Act, also referred to as the ACA. The goal of the PPAC is to help decrease the number of uninsured Americans and reduce the overall cost of healthcare. And the PPACA, which established the Health Insurance Exchange, the HIE, to create a more organized, competitive market for buying health insurance. This makes the employers have to offer a choice of health insurance plans. They have to certify the plans that they participate in and provide the consumer with the information and options regarding for that. So everybody who has a job who offers benefits, you get this package where you have to choose what insurance plan that you and your family would like to go with that is cost effective for you. So it serves individuals buying insurance on their own and small businesses up to 100 employees. And each state must establish its own HIRE or may opt to allow federal government to establish and operate for its residents of that state. So as of 2014, it requires that most people have health insurance, and it requires them to pay a tax penalty if they don't. So if you do not have health insurance, you will pay a tax penalty. It's commonly known as the individual's mandate because it requires individuals rather than organizations to acquire this health insurance. So, what the Affordable Health Care Act did is it expanded the income criteria for who is eligible for Medicare. Um, it decreased the number of uninsured people. It improved healthcare outcomes. It it streamlined healthcare delivery, and it increased overall expenditures on healthcare. So, your role as it comes to health insurance policy is that you want to gather all the information that you can from the patient. You want to answer the patient's questions regarding how health insurance works and how the amount owed determines for any given procedure. You want to be able to verify the patient's insurance coverage and explain that coverage to that patient so that patient is aware of what's going on during the insurance process. You also want to know how to prepare health insurance claims accurately, follow up on past due claims, and pursue unpaid bills. Health insurance, also called medical insurance, is a contract between the insurance carrier, the person who owns the insurance policy, known as the member. So we have a member, subscriber, insured, or policyholder. For those covered by government policies, the term beneficiary often used and refers to individuals who qualify for the program. So we want to verify the verification of benefits, also known as the VOB, is the process to determine the patient's eligibility. So the family members are called dependents. The spouse of the unmarried domestic partner, children, and stepchildren, these are called dependents. It's important to know exactly how each dependent is legally related to the member. So you cannot say that your cousin's daughter is your daughter to get health insurance. They have to be legally related by adoption, by power of attorney, by guardianship before you can provide with that insurance. So in order to purchase a commercial health insurance policy, a policyholder pays a premium to the insurance carrier. The healthcare providers establish a fee schedule which lists their charge for each service that they provide. The fee schedule is organized by a type of service and current procedural terminology, also known as a CPT code. They charge on a fee schedule known as a provider user charge. The allowed amount is the amount the insurance company considers to be the appropriate fee. So then we have an out-of-pocket expense. This deductible is a monetary amount that patients must pay to the provider for healthcare services before the insurance company begins to pay. Some people have $1,000 deductible. Some people have a $2,000 deductible. Some people have a $5,000 deductible. Those fees have to be paid before your insurance company will pay. So plans with lower deductibles tend to have higher premiums than plans with high deductibles. Deductibles may not be required for services. So co-payments are fixed dollar amounts that the patients pay at the time of service. A co-insurance is a fixed percentage of the charges that the patient pays. The different types of visits or different types of providers may have different co-payments or co-insurance amounts. So most government programs require a co-payment or co-insurance. When medical office bills payments insurance, the patient signs an assignment of benefits which authorize the insurance company to pay the benefits directly to the provider, so they will send the money to the doctor's office and not you. So in a managed care plan, the government programs assigns the benefits, usually part of the provider's contract, and it's automatic. So most insurance companies will not pay for pre-existing conditions. This is a historically health insurance plans have exclusions, rules that limit when and how much the benefit is required to pay the benefits. Many of these restrictions being eliminated as a result of the Affordable Health Care Act. So starting in 2014, all group insurance policies must offer coverage to everyone who applies, regardless of the pre-existing condition. A pre-existing condition is any condition a patient was diagnosed with or treated for before beginning the coverage with a new insurance plan. Health insurance companies are not allowed to charge more to people with pre-existing conditions, and they cannot exclude coverage of the condition of the insurance policy because you have a pre-existing condition. Meaning that if you have asthma and you leave your current employer or you leave your current insurance company and go to another one with a different rate, they cannot. It's against the law for them not to offer you insurance because you have a pre-existing condition. So we got HIPAA compliant. Everything that we do is HIPAA based. Um, because of HIPAA, a pre-existing condition is covered without a waiting period when a patient has been continuously insured for 24 months before joining the insurance plan that they're on now. The HIPAA certificate of coverage documents the nature and the length of the coverage with the plan. So patients must submit it to the new plan to establish proof of their continuous coverage over the past 24 months. So HIPAA legislates and it restricts insurance companies from requiring patients to wait any longer than 12 months from the dates that their new insurance coverage began to be covered for a pre-existing. So then we have medical necessity. This is the process of establishing medical need for services. So one of several criteria payers use to determine is how much they will pay for a particular service. I mean, the payer establishes its own definition of what medical necessity is, and it writes it into each insurance policy. So they get to determine what is medically necessary in their eyes as it results to your health care. Medicare can pay only for services medically necessary that are defined for the services that they are supplied to them. They are needed to diagnose or treat a medical condition or improve functioning of a malformed body member. Medicare can pay only for services medically necessary, defined as services and are supplied to them. So it has to meet the standards of a good medical practice in the local area. So your practice has to meet standards for Medicare. If it does not meet those standards, you cannot accept Medicare patients. And they're not mainly for the convenience of the patient or the physician. Payers must also establish criteria for specific conditions. When a provider recommends a treatment that varies from the insurance company's standard list, it requires you to get what we call a prior authorization and provide special reports to justify this service. If you don't, the claim will be denied. That it was unable to be processed and found to be ineligible. And if you process that and it was denied, your office does not get paid. So insurance plans may limit coverage or the required pre-approval for elective procedures. Medical assistants should not manipulate the codes in a way that distorts or alter diagnosis and procedures as documented in the medical record. This is unethical and fraudulent, and it can have jail time and penalties associated with it. So there are types of insurance. We have indemnity insurance. That means it pays for loss experienced by another person. The plan covers the patient's medical care expenses with few restrictions. It's also called a FFS plan, which means it's a fee for service. It allows patients to seek care with any covered healthcare providers for any covered services. Insurance companies reimburse healthcare providers the actual fee charged for each service. The practice is believed to have contributed to rapid rise of healthcare. Indemnity plans are very rare today. We see a lot of MCOs, which are managed care plans, also MCO. These are companies that attempt to control the cost of health care while providing better outcomes. These companies contract with physicians, hospitals, and other providers to offer services for a lower fee. The managed care plan programs have a contract with government programs, private health insurance companies, and self-insurance plans to promote exclusive network of participating providers, or a PPO, which are preferred providers. These patients are responsible for the lower out-of-pocket costs for deductibles, their co-insurance, their co-payments, if they select a non-participating provider. So that means if Dr. Lampkin is my provider that's on the list and I decide to go to Dr. Hodges and Dr. Hodges is out of pocket, I am responsible for all those fees. So smaller out of the advantages of a managed care is that we have smaller out of pocket expenses for patients. We have a nominal copay